Good morning. Thank you for the honor of being present here. And the talk of my study is implementation of a new viscoelastic testing system in cardiothoracic surgery and my experience with the Quantra. So today what I would like to talk to you about is obviously a comprehensive patient blood management program that keeps focus on the patient and on every single drop of blood. The call for bleeding management with viscoelastic testing. I'm going to describe to you how the Quantra works, the technology, the design, the interpretation, and the operation. And I would like to, if you would allow me, to present some of my data and my experience with the Quantra device. These are my current disclosures. So every reasonable effort should be made to avoid allogeneic blood transfusion. We all know that. Every drop really counts in its own way because trying to avoid transfusions obviously decreases morbidity and mortality and also is a cost-saving measure. This is a study that came out just this month in the Annals of Thoracic Surgery. It's an amazing retrospective study. So what they did is they went to the STS database and pulled out an entire decade of isolated coronary artery bypass operations and isolated aortic valve replacements. That was a total of 2.1 million encounters. Out of those 2.1 millions, they took out the patients that received blood, 847 plus patients. And of those patients, they looked at patients that only got 1 unit of blood, and they had 206,000 patients. They went back to the 1.3 million that got no unit of blood, and they propensity matched with something like 25 different factors to best match those 206,000. So they compared 206,555 patients that got no units of blood to 206,555 patients that got a unit of blood, and they looked at the results. And the results, actually, I was quite surprised at. Everything, reoperation, renal failure, prolonged ventilation, stroke, and mortality was significantly elevated in patients that got 1 unit of blood. So like was mentioned here before, we should go from why give 2 when 1 will do to why give 1 when none will do. What that does is make what we do with patient blood management extremely important in trying to save as many blood and blood products as possible. As Professor Spahn said, I was very fortunate to be involved with the STS, SCA, AMSECT, and SABM update, which is now not blood conservation, but clinical practice guidelines on patient blood management. And as was just mentioned, goal-directed transfusion algorithms, which incorporate point-of-care testing, such as with viscoelastic device, is now a Class 1 recommendation. It was not before. As was also mentioned, there are numerous viscoelastic testing devices on the market. They all do a very, very good job, and I'm going to talk to you about my personal experience. So my personal experiences with the Quantra, and I'll talk a little bit later about how I got there. But the Quantra is a little bit different. It's a lot different than the other viscoelastic testing device because it works on a completely different system. It works on what we call SEER, or sonic estimation of elasticity via resistance. So basically, a sound wave is generated and aimed at the clot, and depending on the stiffness of the clot, which affects the sound waves, causes a certain displacement, which is then turned into a shear module estimation. The sound waves go at 1 per second, and the stiffness of the clot is expressed in hectopascals. So this is the display that you see on the Quantra. The top display shows CTH, CT, and CTR. CTH stands for clotting time with heparinase. CT stands for clotting time. CTR is the ratio of the CT over the CTH. the bottom display will show clot stiffness and the platelet contribution to clot stiffness, as well as the fibrinogen concentration to clot stiffness. The CTH will show the time for the clot to form with heparinase, so inactivating the heparin. So if you, and the CTR shows the presence of heparin if your clotting time is significantly higher than your clotting time with heparinase. On the bottom, obviously, the platelet contribution to the clot stiffness could denote a platelet deficiency, and the clot stiffness due to the fibrinogen will show a fibrinogen deficiency. The best thing about viscoelastic testing, and especially this device, is the speed in which we get the results so that we can treat the patient much more on time. So with the top display shows that will start coming up within 3 to 5 minutes. And like I said, it will show the clotting time ratio, and the clotting time with heparinase. Bottom display will come up in 13 to 15 minutes. And if the clotting time is significantly elevated to the clotting time with heparinase and the clotting time ratio is higher than, let's say, 1.3, it will tell you that you have residual protamine. If both the clotting time with heparinase and clotting time are elevated, it will tell you that you probably need PCC or FFP. In the lower panel, the clot stiffness will show you whether it's in the green or not, and if it's not in the green, and then each one of those parameters, the platelet contribution as well as the fibrinogen contribution, will show you what may be indicated in this particular patient. So, like I said, speed is of extreme relevance. If you have a bleeding patient, let's say in this particular scenario, a patient bleeding at 300 milliliters per hour, using conventional plasma-based test, a lab sample is sent to the lab in the first 5 minutes or so. It will take approximately 80 to 90 minutes to get your results back, and then if you order cryoprecipitate, maybe another half hour. So now you are treating a patient 2 hours later when the scenario is over here. The coagulopathic scenario may have completely changed. Whereas if you can get a faster diagnosis in 10 to 15 minutes, and whether you give fibrinogen or you give cryoprecipitate for that particular sample, you're treating a patient in a much more real time and you have a much better coagulopathic picture. And for those that would like curves, there are curves as well as a trend screen. And the trend screen can actually be quite helpful because even though sometimes patients may stay in the green area of the dials, patients that show a significant trend can be treated with the appropriate factors as necessary. So, what I like about this is that I don't have to think about the brandy or the beer glass or the wine glass, etc. So I would like to tell you about my experience with viscoelastic testing. It actually goes far back. I started in 1989 at Good Samaritan Medical Center, which is in Phoenix, Arizona. Phoenix is a big city. It's got 4.5 million people. I was there from 1989 to 2007 and was chair from 95 to 2007. We had 755 beds, and we're doing anywhere between 700 to 1,100 open hearts per year. In the early 2000s, we got a viscoelastic testing machine. And at that time, things were not quite as developed as they are today. And we called it our random number generator, because oftentimes the patient would be bleeding and the study would be normal and vice versa. In 2007, I was recruited to a beautiful town in Arizona called Prescott, much smaller place, population of 1/20th of Phoenix, and been the chair there since I arrived in 2007. And we have 200 beds, about 220 to 250 hearts. We do not do ECMO and transplants. So I was responsible for deciding whether we should have whatever I started the program. There was no heart surgery before then, so I basically had the run of the house. When I looked at viscoelastic testing at that time, I did not feel that it was a wise use of my money because of my previous experience in the early days of viscoelastic testing. But I've been very involved with patient blood management since then. Towards 2017, 2018, it was obvious that viscoelastic testing had significantly improved, and I felt that it should be part of any concerted cardiac surgical PBM program. So in 2019, I asked the two companies that were on the market to come and demonstrate their machine. And we were about ready to make a decision. Both those devices worked very, very well. But I heard that there was a new device coming on the market, but it was not necessarily ready yet. So I waited a couple of months until I got approval, and I tested that. And I would like to show you my very first patient of how viscoelastic testing can help, as well as a second patient once you get comfortable with viscoelastic testing. So my first patient just happened to be a reoperation on a double valve, aortic valve, mitral valve procedure. And you would expect that that's going to be a bloody operation. The patient's platelet count was normal. The PTT was normal. This was the first panel I ever saw on the Quantra. And you'll notice that the CS, the clot stiffness, is below normal. It's below the green sign, and it looks like it's secondary to the platelet contribution for clot stiffness. So I ordered a unit of platelets before we started the operation, because if I'm going to believe this, I'm going to give this patient platelets. I almost routinely use autologous normovolemic hemodilution, so we had 2 units available. When we were on pump, this is the display that we got. So the CTH was in the normal range. Obviously, we're on cardiopulmonary bypass. We're over-heparinized. There's no clot detected in the CT. But once again, the clot stiffness was severely reduced, secondary to the platelet contribution. We came off pump. I gave the 2 units of ANH. I gave the platelets that I already had ready so I could treat the patient right there at that time. And the chest tubes, while we were in the operating room, we're putting out about 150 cc's. You'll notice here it's 11:36 in the morning. So I ordered 2, with this result, I ordered 2 additional platelets, and I gave one unit. And we waited in the OR, and now everything is normalized. It's 12:23 p.m. on September 30th, 2019. Chest tube stopped draining. Obviously, the Quantra showed that it returned to normal. I took that patient with my 3rd bag of platelets to the intensive care unit and repeated another Quantra. And once again, everything is in the green. The chest tube was minimal, and I was able to return that unit to the third, second unit of the second ask for platelets, to the blood bank. So without viscoelastic testing, and I think most surgeons have their routine way of treating patients who are bleeding, and that routine way is give the cheapest stuff first, FFP, then give platelets, then give cryo, then give your PCC, then give your factor 7, et cetera, et cetera. Basically treating what they think may be a coagulopathy, but still unsure. And that's the way I was doing things. So in this particular patient, the very first patient, I believe I saved 2 units of FFP, at least a unit of platelets, and maybe a few packs of cryo. No FFP was given. This is the trend on that patient. I'm going to quickly go through the second case. And the important thing here is this is 2 years later. August 16th, 2021. I have a patient, a 64-year-old with an MI, hypotensive on a balloon pump that needs to go to the OR relatively emergently. This is what I get. Once again, the clot stiffness is somewhat low, once again due to platelet contribution. In the immediate postoperative period, so this is at 10:49, I see that our CTH and CT is elevated. The INR, the ratio is less than 1.3, and the clot stiffness is low, significantly due to platelet contribution. The patient was having diffuse oozing, 200 cc's in the chest tubes within 30 minutes. I transfused 1 unit of platelets, 2 units of FFP, and transferred the bleeding patient to the intensive care unit, where normally I would have waited in the operating room. This will show you that at 128, obviously the patient is still bleeding. Obviously the Quantra result is still significantly elevated. I continue to give platelets and FFP at 1539, so we go by 349, but 1539, I can see that my blood loss is significantly decreasing. Now my Quantra is back to normal, and no treatment over the next several hours and into the night. So my point with this patient is 2 hours later, I'm so convinced that it tells me, viscoelastic testing tells me that a patient is coagulopathic and not because I forgot to tie something up. So after having this new device in our hospital, I think we were the second or third hospital in the U.S. to have this device. I said, well, let me develop an algorithm. And as you know, there's multiple algorithms that are available. And I would like to, so that the other surgeons in my group can very easily look at the dials, look at the algorithm, and go right here and decide what to give. So I wanted to compare my previous experience without viscoelastic testing to my ongoing experience. So we did a study that we looked at all open heart patients, including multi-valve operation, cabbages, redos, aortic repairs, dissections. Once again, we don't do ECMO or transplants at my institution. And I looked at 64 propensity-matched patients, pre-viscoelastic testing and post-viscoelastic testing. This was actually just published this week in the Journal of Cardiothoracic Surgery. And you'll see one problem that we had with this study was that the INR in the post-Quantra was somewhat higher than the pre-Quantra. And I'm not sure why that is, because everything else was the same. Nevertheless, that's what it was. And these are the results. What's interesting in these results is that pre-Quantra, you can see that so blue is packed cells, red is FFP, green is platelets, purple is cryoprecipitate. You can see that our FFP utilization, like I told you, this was and is first-line therapy for many cardiac surgeons without viscoelastic testing, because it's the cheapest thing that we've got to give and hopefully will help with clotting, went from 35 patients to 1. Also, we had further reduction. Also, what's interesting is, once again, without viscoelastic testing, you're throwing the kitchen sink at the patient. So this is the number of types of blood products that you use. So whether you used just red cells or just FFP, you would be in this category. So you can see in the post-Quantra area that we use significantly more single blood product, because we are specifically aiming at what we need as opposed to just treating coagulopathy. And then we looked at the money that we saved on just 64 patients, and you can see that 64 patients, we saved $40,000. So that was quite good, I think. So in conclusion, I want to ask you, how would you like to treat your next coagulopathy? And what you want to do is treat the particular coagulopathy. You want to laser point guide it to what you need. Still, with the STS and multiple other societies using making viscoelastic testing a class 1 recommendation, I would say that at least half of the open heart programs that I know either don't have viscoelastic testing or have viscoelastic testing and not using it effectively. But hopefully that will improve. So thank you very much. It's a pleasure to be here in Greece. Thank you.